Okay, today's presentation is going to be on ischemic stroke, and it's going to talk about the difference between alteplase and heparin for treatment of patients who have suffered from ischemic stroke. Objectives. By the end of this presentation, the nurse will be able to describe the pathophysiology and signs and symptoms of an ischemic stroke. They will be able to contrast the mechanism of action of alteplase and aspirin, as well as contrast the efficacy, safety, cost, and expected outcomes of treatment with alteplase and aspirin for the patient with ischemic stroke. The content standard that I use to prepare this presentation are the guidelines for early management of patients with acute ischemic stroke, 2019 update to the 2018 guidelines for early management of ischemic stroke, a guideline for healthcare professionals from the American Heart Association/American Stroke Association. Ischemic stroke. Local thrombus formation or emboli occluding the cerebral artery, resulting in decreased cerebral perfusion. Thrombi are the result of carotid atherosclerosis and plaque rupture, while emboli are the result of stasis of blood in the atria or ventricles, resulting in clot formation. That clot can then dislodge and travel to cerebral circulation, at which point the thrombi or the embolism result in arterial occlusion, decreased cerebral blood flow, and cause ischemia and ultimately infarction distal to the occlusion. Clinical presentation. Some of the most common signs and symptoms are unilateral weakness, inability to speak, aphasia, dysarthria, loss of vision, vertigo, diplopia, falling, and altered level of consciousness. In stroke, every second counts. It's important to recognize the signs and symptoms early and call 911 immediately. Knowledge check number 1. A patient presents to the emergency room with sudden onset right-sided weakness, aphasia, and altered level of consciousness. The patient is diagnosed with an ischemic stroke. The nurse knows which of the following may be the cause. Select all that apply. An emboli lodged in a cerebral artery, decreasing cerebral blood flow and causing ischemia. Rupture of a cerebral artery, causing blood to leak into the surrounding brain tissue, decreasing cerebral blood flow and causing ischemia. Carotid atherosclerosis narrows the lumen of the plaque. Eventually, plaque ruptures, resulting in platelet aggregation, thrombus formation, and obstruction, or venous occlusion, decreasing cerebral blood flow, causing ischemia. The correct answers are A and C. A is the result of stasis of blood in the atria or ventricles, resulting in clot formation. That clot can dislodge and travel to the cerebral circulation, while C is the second cause of ischemic stroke. B is incorrect, although it could cause similar symptoms, but is the description of a hemorrhagic stroke. And D is incorrect, because arterial, not venous occlusion result in your typical ischemic strokes. The number one treatment for ischemic stroke is alteplase, also known as TPA or tissue plasminogen activator. Alteplase works by acting directly or indirectly to convert plasmin to plasmin, in turn cleaving fibrin and lysing thrombi or emboli. It's important to note that clots become more resistant to lysis as they age. As the emboli dissolves, thrombi form and can result in local platelet aggregation and thrombus formation distal to the original clot. Strategies to prevent this include administration of antiplatelet or antithrombotic agents such as aspirin or heparin when appropriate. In contrast, the mechanism of action of aspirin is different. Aspirin inhibits thromboxane A2 synthesis by acetylation of a serine residue on the active site of COX-1, thereby irreversibly inactivating the enzyme. The balance of mediators favors the anti-aggregatory effects of prostacyclin, thereby preventing platelet aggregation. This effect is rapid, and the result is the suppression for the life of the platelet. Knowledge check number 2. True or false? The nurse is providing patient education for an ischemic stroke patient. The platelet patient completes a successful teach back when they state, I received Alteplase. It dissolved the clot in my brain. Now I take aspirin to keep my blood cells from sticking together. This makes it less likely that I will have another stroke. The correct answer is true. Alteplase acts to convert plasminogen to plasmin, in turn cleaves fibrin and lyses thrombi or emboli, while aspirin prevents platelet aggregation. Alteplase efficacy is a standard of care in patients without hemorrhage. It can be used more recently in conjunction with thrombectomy to improve outcomes even further. It needs to be initiated within 4.5 hours of symptom onset, so it is important that the original symptom onset is witnessed by someone so that we know if it's been longer than 4.5 hours. If it's been longer than 4.5 hours, the risk of conversion to hemorrhage increases, and that's why TPA isn't given after that. Contraindicated in pregnancy, large wounds, brain tumor, head trauma, intracranial bleeding, and metastatic cancer. Safety. The biggest risk with alteplase is hemorrhage. Thrombotic agents affect unwanted thrombi and beneficial hemostatic plugs equally. So, unfortunately, in patients with clots, that hemostatic plug can be dissolved and result in massive bleeding. The cost of alteplase is incredibly expensive. It costs $7,000 just for the dose of medication that's given to the patient. And then, in addition to that, the monitoring in the ICU for 24 hours and a few days in the hospital can be incredibly expensive. The expected outcome with alteplase treatment is improvement in signs and symptoms of stroke, as evidenced by improvement in the NIH score from initial evaluation. Ongoing NIH monitoring takes place in the ICU for possible hemorrhagic conversion. Aspirin. Aspirin does have a couple drug interactions. The higher the dose, the greater the related drug activities, and these can affect warfarin, phenytoin, and valproic acid levels. Aspirin also interacts with NSAIDs because NSAIDs also inhibit COX-1 by transiently competing at the catalytic site. Aspirin should be taken at least 60 minutes before or 8 hours after NSAIDs. Efficacy. Aspirin results in the complete inactivation of platelets with at least a 75 milligram daily dose, making the recommended dose between 50 and 325 daily. Safety. With aspirin, bleeding time is prolonged and can result in complications like a hemorrhagic stroke, gastrointestinal bleeding, especially at higher doses. And for overdoses, toxicity can be fatal, especially in children. The cost of aspirin, it's available over the counter for the 81 milligram dose. It's between 2 cents and 6 cents, depending on the brand you choose. So it's incredibly cost effective treatment for patients. The expected outcome is a significant risk reduction for repeated events, especially when it's combined with clopidogrel. Knowledge check number 3. True or false? Alteplase affects thrombi and emboli the same as it affects hemostatic plugs, making its greatest risk bleeding. The correct answer for this question is true. The composition of all clots is the same, therefore alteplase affects helpful hemostatic plugs the same way it would affect a thrombi or an emboli. Knowledge check number 4. The nurse is performing discharge teaching for her patient with an ischemic stroke. What medication should the nurse expect the patient to be discharged on? Select all that apply. Ciprofloxacin, aspirin, alprazolam, clopidogrel. The correct answers are both B and D. For patients who are not at high risk for bleeding, aspirin and clopidogrel, when taken together, show the greatest risk reduction for stroke recurrence. Ciprofloxacin is an antibiotic and has no role in long-term stroke management. And alprazolam or Xanax is a benzodiazepine that has no role in stroke management. Here are the references that I used to create this presentation today. Thank you for participating in this stroke education.